Thank you, Professor Bourdel. I am so pleased to talk about this topic. And really, I am so pleased because I am your student. And I learned to do my first coronarography was Professor Bourdella. So I am so pleased to be here. So I think it's a relevant topic because we get this year a new consensus of SCAI, and we will get after that a joint session with SCAI, and we have here the past president of the SCAI, a member of the SCAI. And I think that if we look at the incidence of this complication, really it has significantly decreased. In 1990, it was about 40%, but it was with BMS. Now, if we have a look at now, the incidence of this complication is about 2 to 3%. As you see, it depends on the material, the stent, the thickness of the stent, and the polymer. But let's see what happened in real life, because these results are the results of randomized trial. If you look to results of real life registry, and here we have the American registry, we see that we find that it's more than 2 or 3%, it's about 10%. And I think the most problem is the problem of recurrent instant restenosis, which occurs in approximately 20% of all instant restenosis cases. And the predictors of this incidence is really the most predictors, the strong predictor is the number of stents layers placed at this location. If we look at the results of our registry, the Tunisian registry, which was performed in 2020, between February and June, we collected more than 2,000 patients, and we found that the risk of instant restenosis when we put DES, it's also high, about 12%. But let's say that this result, it depends because we have many diabetic people in our cohort. More than 50% of our patients are diabetics. For the causes of this complication, it's classic, we know, maybe we have stent under expansion, stent fracture, neoantimal hyperplasia, but I think the specific mechanism of instant restenosis for drug-eluting stent, it's neoatherosclerosis, and if we compare the instant restenosis between the two stents, you see that for BMS, it's always neoantimal proliferation. For this, it's neoatherosclerosis and especially inflammation. The restenosis will be diffuse for BMS, but it will be focal, and it involves usually the stent ages. And if we look at OCT, we will note that it will be a homogeneous high signal tissue iconicity for BMS and heterogeneous for DES. I think that intracoronary imaging now, it's a must in 2023. Of course, we will treat only patients who will show positive stress test. But I think why this tool is very important, because it will identify the mechanism of instant restenosis. It will allow to optimize the interventional treatment, analyze the number of stent layers at the lesion site, and assess the expansion of each layer of stents. So I have no much time, but you can see the difference between neoantimal hyperplasia with homogeneous bright uniform layer, neoatherosclerosis, and stent underexposition. You see, with OCT, we can assess the number of stent layers, and we said from the beginning that the number of layers is the stronger predictor of instant restenosis. We used to use Roxanne-Meran classification, which is a specific classification to BMS. Now we have two new classifications, a classification which was published this year by SCAI. As you see, this classification is based on time interval and causative factor. Early, if it happens during the 30 first days, and the morphological substrate is undersizing, under expansion, stand fracture. Late, between 30 days and 1 year, and very late, after 1 year. I think this is a relevant classification because it will inform us about the mechanism of instant restenosis. Another classification is the Waxman instant restenosis classification, which is also based on the mechanism of instant restenosis. And this is very important because it will allow us to choose the treatment option after that. For example, if we see the class 1, it's mechanical. It means that it's about underexpansion or stand fracture. And you see for underexpansion, we have to choose high pressure balloon, stand fracture death. We will see after that how to manage this complication. So I think we should forget uncoated balloon now in 2023 because it is also the source of complication and risk of restenosis. No clear evidence guides which type of death should be used to treat instant restenosis. There is no consensus on whether the stand type should be changed when an additional death is implanted. And I think in 2023, we must combine many treatment options. We must prepare well our lesion. Even if we will use drug-eluting balloon, we can start with cutting balloon, scoring balloon, and then we will use drug-eluting balloon. So preparation is crucial, and we must really prepare lesion with residual stenosis less than 30% without flow-limiting dissection. I think this is a full slide, but the main conclusion is that DEP is now well demonstrated that it is superior to uncoated balloon. DEP is not inferior to DES, but we have to know that not all the DEP are the same. Also, how to prepare lesion. Scoring balloon and cutting balloon are very interesting tools because it will minimize barotraumatism to the vessel and avoid slippage of conventional balloon when inflated over fibrotic scar. I think now there is new perspective. It's the bioresorbable vascular scaffold, and yesterday we get a very nice talk from our friend Mamas about a new scaffold. Also, I think if you will consider the mechanism of instant restenosis, if it's about well-expanded stand with exuberant neoantimal hyperplasia, we can use cutting balloon followed by drug-coated balloon. Under expansion with the soft tissue, we can use a high-pressure balloon, the APN, but if it is about calcified lesion, we should better prepare lesion using rotablator or lithotripsy and shockwave. I think the problem of repeat instant restenosis is really a big problem because we have to avoid a third layer stand. We should use drug-eluting balloon, and if there is no other option, maybe we can opt for cabbage. So I will finish by this case from our department. It's a 70 years old patient who is diabetic. He got 2 deaths in 2019, but there was a gap between the 2 deaths, and he showed an acute coronary syndrome this year, and as you see, there was a restenosis, instant restenosis. So we tried to prepare the lesion with balloon and coated balloon, 1.5 millimeter, but we failed to cross the lesion with a 2 millimeters balloon. So we decided to go rotablation in this patient, as you see, using 7 French catheter and 1.5 bar, and then we get very good results. But unfortunately, as you see, 3 months after, we get again a restenosis, and we tried to improve result using drug-coating balloon. I think I have just one conclusion. It's before putting a drug-eluting stent, we must prepare our lesion well, because failing to prepare is failing to fail. Thank you.